Good afternoon. Thank you for the pleasure of being able to present to you today. My name is Farah Husain, and I am the Chief of Bariatric Surgery at Oregon Health and Science University in Portland, Oregon. I wish I could be there with you, but of course, we live in crazy times. So I just wish you all a safe trip and hope things are going great with Sages. We do have some disclosures. I do provide lectures for fellows and surgeons for gore, ethical, as well as electronic. My more applicable disclosure today is likely that I rarely do one anastomosis gastric bypass, but I do think it's a fun surgery and technically an easier surgery to do than the Roux-en-Y gastric bypass, which I do many more. So we all know the anatomy involved in these cases when we look at our traditional Roux-en-Y gastric bypass versus the mini or one anastomosis gastric bypass. We know that the pouch size is considerably longer with the one anastomosis gastric bypass, and a loop Villeroth type anastomosis created as a gastric vaginostomy. And so why would we not all do this procedure that seems to be more straightforward, longer pouch, potentially less tension on an anastomosis? And why is it not more accepted in our setting, particularly in the US? When we look at the evolution of operative procedures for the management of morbid obesity as scripted by the Buchwalds, we know that there have been a lot of iterations of bariatric surgery. The original Mason-Ito procedure done in 1966 was a loop gastrovaginostomy. Then did many variations following that: divided gastric bypass, non-divided bypass, loops versus Roux-en-Ys. In 1977, they landed more on the Roux-en-Y gastric bypass. And why? Well, they found that it actually avoided tension at the gastric vaginostomy, and most importantly, that it prevented bile reflux gastritis. So why is this even important? Well, the presence of bile in the stomach correlates well with the presence of gastritis. The histology often shows foveolar hyperplasia, edema, and the paucity of inflammatory cells when you get bile reflux gastritis. These features are similar to those seen in chronic NSAID use and other chemical injuries to the stomach. So it's very important to exclude those pathologies if you see this kind of pathology, and ensure the patients aren't using a high dose of NSAIDs or other chemicals that could cause this. But it also mimics a little of what we see with NSAIDs and increased risk of other phenomena. So bile reflux gastritis and intestinal metaplasia of the cardiac. Professor Dixon out of Leeds presented his data, and this showed that intestinal metaplasia was a precursor to gastric cancer. He had biopsies of 267 patients with dyspepsia, and the presence of bile reflux was associated with intestinal metaplasia of the stomach. And obviously, he also showed that intestinal metaplasia is a precursor to gastric cancer. So this was all a concerning finding at that level. What about surgeons who do one anastomosis gastric bypass? When these surgeons were surveyed for obesity surgery in 2021 about their techniques and outcomes, they had 742 surgeons respond. The revisions from malnutrition and steatorrhea were reported to be about 37% of the surgeons saw this and needed to do a revision for one of these reasons. Revisions for severe bile reflux were reported by 45% of these surgeons, and 43% of them revised them to a Roux-en-Y gastric bypass. 5 of the 98 mortalities reported by these surgeons were for liver failure or malnutrition. So their exact quote from the paper was that there are infrequent but potentially severe specific complications, including malnutrition, liver failure, and bile reflux that may require surgical correction after one anastomosis gastric bypass. And I would say when you contrast this with Roux-en-Y gastric bypass, it's very, very rare that we would see liver failure or malnutrition as reasons for revision. Now, it does happen every once in a while, but I would venture to guess it'd be less than 5 of 98 mortalities, whereas our mortalities tend to be more in the realm of VTE, sudden cardiac issues, and respiratory-related issues, particularly those with untreated sleep apnea. So to see liver failure as still a visible issue is a bit concerning in the world of the one anastomosis gastric bypass. And then we want to look at the efficacy and safety of Roux-en-Y gastric bypass with one anastomosis gastric bypass. This TOT study out of Tehran was a retrospective study that was maintained over 5 years of a database. This was a prospectively maintained database. And they looked at Roux-en-Y gastric bypass with 150 centimeter roux limb and a 50 centimeter BP versus one anastomosis gastric bypass with 200 centimeter BP and a one anastomosis gastric bypass with 160 centimeter BP. And in this study, they found that the groups were very comparable for post-op complications, except for the incidence of protein calorie malnutrition, which happened more in 200 centimeter one anastomosis gastric bypass group than any others. 7 of those patients did require revisional surgery, and 1 patient did need parenteral nutrition, but no revision at that time. They did not see that kind of protein calorie malnutrition in any of the Roux-en-Y gastric bypass patients. And so that's a significant intervention that is needed in the one anastomosis world. And then, of course, as surgeons, we always want to know about the RCTs, right? What does the randomized controlled trial show? What have we seen when we compare one anastomosis gastric bypass versus Roux-en-Y gastric bypass head to head? And the Omega trial and the Taiwan studies both have done this. The Omega was the largest study at 234 patients that were randomized into either one anastomosis versus Roux-en-Y gastric bypass, and the Taiwan study was 80 patients. What they did find was, not surprisingly, the one anastomosis gastric bypass was a shorter procedure in the operating room, and it was easier to perform. It had similar weight loss to the Roux-en-Y, but the one anastomosis gastric bypass appeared to have better glycemic control. And this was reflected by a reduced hemoglobin A1C to a greater degree at 2 years in the Omega study. Now, there was 100% resolution of metabolic syndrome in the Taiwan study in, I believe, all patients. The one anastomosis gastric bypass patients did have more malabsorptive problems, though, and this was consistent through all of the previous studies that we'd seen. They presented with a lower hemoglobin overall, so higher risk for anemia, more revisions, and again, the majority of the revisions were related to adverse malnutrition events in the patients. And bile reflux with 16% of patients had bile in their pouches in these studies as well. The bile reflux, although it was noted, admittedly did not always influence quality of life, but there was evidence of it, and we need to survey that and follow that because the presence of bile in the pouch was more readily available and seen in the one anastomosis group rather than the Roux-en-Y group. So we'll conclude with saying, if we know that we get more bile reflux gastritis, and that's more carcinogenic, we get more malnutrition and more anemia, as demonstrated by these studies. The question I have to ask you is, do we default to the one anastomosis gastric bypass because it's easier? I don't know if that's a good default necessarily. And considering that the malnutrition and liver failure rates are significantly higher than what we would see with Roux-en-Y gastric bypass, we do have to remember that when we're treating obesity, there's a lot of stigma involved. We don't want to give people the most radical thing with the coin phrase that you may lose more weight at a risk to the patient themselves. So I like to say that we do need to be facile with all techniques and prepared to use them in different situations. And either way, whatever you choose, do your technique well and be open to modification if the results are not what you would expect. It's the best way for us to move forward. Thank you very much for your time. Enjoy your SAGES meeting. I'll see you during the Q&A.